Hi, good morning. I'm Nathan Riding and scientific researcher here at Aspetar. And today I've got the privilege of talking to you about the W's. And the W's are of the who, what, when, and why of cardiac screening in athletes. Now, I pre-recorded this on Saturday, but in light of events on that day, I wanted to do it again and first of all start by saying my thoughts are with Christian Eriksen, his family and his friends. And it does put it into perspective, doesn't it? That it's not Christian Eriksen, the football player, but him as the father, the son, the brother and the husband. And so my thoughts really are with them. And I just hope that the work we are doing here and around the world in sports cardiology will go to building a better future. And I guess we have to start with why. Why should we screen? Well, before talking about that, I just want to highlight the wonderful work by the medical staff at the Denmark and Finland game, sorry. And it was clear to see that this must be the #1 strategy. AED implementation in stadiums, sporting venues and schools, and even in the community as well. Adherence to the emergency medical plans and community CPR training should be the fundamental basis and start to any prevention of sudden cardiac death. Now, in the UK, this is the only place I've got this data for, but if you are querying where your nearest AED location is, there is this website of heartsafe.org.uk where you can find your nearest AED location. As we move on to why we perform cardiac screening, the American Heart Association highlight that it's appropriate to screen based on ethical, medical and legal grounds. And the European Society of Cardiology concur with that, and also highlight that screening is the ultimate objective of screening is to aid in the detection of silent conditions which may predispose an athlete to a sudden cardiac death. And indeed, it is the leading cause of sudden death in young athletes. The rate is threefold higher in athletes than non-athletes. And cardiac arrest or death may be the first presentation in up to 80% of cases. In those with a predisposing condition, exercise can act as a trigger. Now that's attributed to the possible interplay between the substrates of fibrosis or hypertrophy and the exercise-induced effects of increased circulating catecholamines, exercise-induced acidosis, dehydration, and electrolyte imbalance. And while 80 to 90% of cardiomyopathies are identifiable with suitable screening strategies, it does mean that 10 to 20% are not. And indeed, it must be acknowledged that screening does not detect all cases. But if it identifies a cardiac disease in a timely fashion, it can be appropriately managed through lifestyle modification, pharmacotherapy, or implantable AEDs. And so there are strategies to help the athlete if a cardiac disease is indeed found. But when we're thinking about sudden cardiac death, we have to acknowledge that there is a large range in incidence depending on study. It can range from as low as 1 in a million, but to 1 in 23,000. But what this does is complicates our understanding of not only the issue, but for the perceived importance for cardiac screening stakeholders, and not only the athlete, but the doctor, or indeed the sporting federation that may be tasked to deciding whether to screen their athletes or not. And such large range in incidence really does complicate the perceived importance. Relating to that are methodological considerations, in as much as what are we actually recording? Are we recording sudden cardiac arrest or death? Now we've seen that a pertinent point is survival of cardiac arrest, and with improved rates of survival, it's likely that we fail to account for those with aborted sudden cardiac death in the incidence rate, and therefore may again underestimate the true incidence of these occurrences. Within the data, we also have to acknowledge and understand how are we recording the data. So is the study design retrospective or is it prospective? When it's retrospective, an article from John Dresner and Kim Harmon in the University of Washington in the USA highlighted that when the study design was retrospective, typically including their data sources of insurance claims and newspaper reports, non-athletes were at higher risk. But flip that, and when the study was had a robust methodology with a prospective design, in fact, athletes seem to be at a higher risk of sudden cardiac death. So again, that has a whole implication on how we interpret the findings. But in terms of why we perform cardiac screening, well, it's already ingrained in some professions, in firefighting in the army, for example. And when we consider that professional athletes are indeed employees of clubs, and if we consider that exercise may increase the risk of a sudden cardiac death, and these athletes are training every single day incredibly vigorously, and that may predispose them to a sudden cardiac death if they are harboring an underlying condition, maybe there is the argument to perform screening for this reason as well. Beyond the detection of sudden cardiac death conditions, screening also has the opportunity for education. Now, this can include health behavior and things like that. And so it has an important role there, but also it may be the sole interaction with a team doctor if you're an individual sport. If you're in a team sport, it's important to build up that rapport with the athlete so they are more comfortable with you as a doctor in disclosing personal information maybe. And importantly, for approximately 50% of adolescents within the USA, screening marks the only interaction with the medical system during their teenage years. Now, there are medical legal duties, but also it may identify other medical conditions. In our institution, for example, we ask questions on female athlete health, checking for menstrual cycle disturbances and energy availability. And so that's an important aspect too. But a study here from Arnhild Bakken, who is now in Norway but did her PhD in Aspetar, looked at the different health conditions that can be identified in a health screening. From a cardiovascular point of view, we highlight that 10.6% had an abnormal lipid profile. And so, for example, if the athlete is on a statin, then regular screening and regular periodic interactions with the doctor can allow for the checking of how that medication is doing, but also in terms of the WADA code, and are the athletes compliant with that? When we move on to what and how should we screen? Well, we see here that out of the 19 of the leading international sporting federations around the world, there are various different strategies and implementations of cardiac screening. And indeed, 42% of them implemented a self-imposed screening protocol. And it goes without saying that all of these undoubtedly have the health of the athlete at the heart of, pun intended, at the heart of what they are doing. But you see that experts disagree, and they may go above and beyond what is recommended by the leading organizations. Indeed, some may include a physical exam and personal history. Some may include the ECG, and some may include the extra step of doing an echocardiogram. Now, the IOC, for example, they recommend the use of personal history, physical exam, and 12-lead ECG. But you can see here from this study looking at team doctors responding to a questionnaire from the Olympics, 20% did not perform screening in their athletes at all. And the reasons cited for this were the cost of the ECG, the cost of further follow-up, and the lack of cardiology consultation. And coincidentally, the countries that did not screen, well, the countries that screened were independently associated with a higher GDP. And so it's very important to highlight that that is the correct approach. If you can't afford the athletes the best quality of care with the cardiology consultation and further follow-up guaranteed, we shouldn't be doing cardiac screening at all, because it's putting the health of the athlete at the risk. And it leads into a nice quote on a similar situation of half of the troubles of his life can be traced to saying yes too quickly and not saying no soon enough. And so it's important to, before jumping into screening athletes, we need to be asking the question before anything gets done. Do we have the health of the athlete at the heart of the matter? And do we have the necessary capability of following this athlete up if indeed they have an abnormal finding? Now, in terms of the specifics of how we perform cardiac screening, then the tool that is adopted by all organizations, irrespective of what they believe, is the physical exam and questionnaire. And while this is quite a simple study, it highlights something incredibly important in that the percentage of adherence to the recommendations in terms of questionnaire and physical exam is as low as 7 to 10% in these Canadian universities when they got questioned about their individual protocols. Indeed, 57% were defined as having an inadequate approach. Now, this meant that they had less than 50% of the recommended aspects of the questionnaire and physical exam within their own protocol. And from this, it's important to highlight education and awareness, because indeed, in a 2014 study, among physicians that were asked about what questionnaires they used for their athletes, only 37% of physicians reported an awareness of this PPE, the pre-participation physical exam monograph. This is quite astounding, really, because the people asked in this questionnaire were the physicians belonging to the member organisation that were responsible for the document's creation. Again, highlighting that the questionnaire and physical exam is the fundamental thing that every doctor learns in a medical school, but we need to ensure that it's done correctly and an awareness of what the protocols are saying. Important because 30% of the forms within these Canadian universities didn't ask probably the most important question, which is regarding a family history of a sudden or unexpected death. Now, with regards to the questionnaire, you can see quite clearly here that there's a large variation in what is asked. And importantly, none of the questions included in the questionnaire have been validated prior to their publication, and they're solely based on expert opinion. And you see here, when we look in more detail, that the definitions and terminology used within the questionnaire differs. And this is important. Within our findings, we found 3.4% had chest pain, 2.1% had shortness of breath. But if you ask an athlete, have you ever had shortness of breath or fatigue out of proportion to the degree of exertion? If that is not explicitly explained, if that is not explained thoroughly, then the athlete, of course, will be like, yeah, of course I have shortness of breath. I'm an athlete, I'm training hard. And so how the questionnaire is administered must be considered, as the questions are highly dependent on how the athlete is interpreting it. Now, the nurses in our institution do a wonderful, wonderful job in going through every questionnaire, every question within the questionnaire with the athlete and trying to facilitate their understanding of what is being asked. But we have to consider that athletes in this situation, in professional teams, for example, may be on the brink of signing a big money contract. And we don't know what their family history is. And so the subjective nature of the questionnaire could actually lead to false negatives. And it's important because the understanding of the athlete of a questionnaire is highlighted here within this UK study, where the percentage of positive findings that the physician evaluated as clinically meaningful was as high as 27-fold lower when the physician asked the athlete explicitly. And so with 35% of USA states permitting non-physicians with little or no cardiovascular training to provide medical school in high school athletes, we must caution that the people administering these questionnaires need to be trained on what the questionnaires mean and how best to interpret and ask these questions. Now, what I've done here is I had a little play around, and it's not been published, not peer reviewed. It's just something I did, which was putting the questionnaires within this reading ease tool. And it's actually fascinating. If anybody wants to help me publish this or something, get in touch. But those bars don't mean anything until you do this. Boom. A score between 60 and 80 is considered easy for a 12 to 15-year-old to understand. Only one of those questionnaires meet that criteria. Indeed, when you use grade or age to determine this, the American Heart Association, according to this reading age tool, has a reading age of 16 to 17. And this Dale-Charles grade level suggests that not only the AHA questionnaire, but the ESC one also requires a collegiate gradual level of understanding to be able to interpret the questions within the questionnaire. And it echoes quite a nice small study published by the University of Auckland this year, where researchers asked 212 professional football players with a median age of 24, so they were not young, if they knew what Marfan syndrome meant. 5.7% knew what it meant. With regards to syncope, just 6.7% knew what syncope meant. And so unless this is explained thoroughly, and if the athlete is doing the questionnaire by themselves, which is often what is done, the likelihood is, if you don't know what they're meaning, this questionnaire, if you don't know what syncope means, the likelihood is you just say, no, I don't have it. And again, leading to the worrying possibility of a false negative. With regards to family history, it doesn't get much better. You can see here the varying terms used within the questionnaires. Indeed, if I had an audience here, I would ask you all, what do you think these terms mean? Legally, a family member includes nieces and nephews, even your in-laws. A relative, from a legal standpoint, is anybody connected to your family through blood or marriage, and I presume other things like adoption as well. And so if the athlete is going through the questionnaire, and another thing that the questionnaires have not interpreted or not accounted for is different languages, different cultures and things like that. Because some people may consider, I don't know, their stepbrother's cousin's auntie as a family member. Yet this would unlikely have an impact on any familial condition, but would be perhaps ticked as a positive finding within the questionnaire. So again, the danger is that this gets overlooked and the athlete undergoes unnecessary further investigation. Other aspects about the questionnaire are, particularly within this question, only one of them accounts for a premature death related to a cardiac condition. Indeed, the age of which a sudden death may occur also differs significantly, from as little as under 35 from the PPE to as high as 55 and 65 in females with the European strategy. Now, what this does in terms of our data is creates a bit of a pickle. If we use a PPE, just 1.1% have an abnormal positive finding for this, but 3.4% if using the ESC. Various different prevalences here. When I took this data and I compared that of a family member to a first-degree family member, that of a father, mother, or a sibling, it was just 1.1%. Now, among our data, among those with a condition associated with sudden cardiac death, 7% had a positive family history, although none of them within a non-first degree relative. Now, while of course this is a small study, it highlights that we need to be careful in asking these questions and understanding the question yourself as a physician or a nurse, but also ensuring that the athlete understands what is being asked. Now I move on to an equally unsexy topic. It's been sparsely looked at in the literature, but the physical exam is a key component to cardiac screening. And like I said at the start, it is a fundamental basic thing that everybody does in medical school. But within the questionnaires, peripheral pulses and Marfan syndrome is only been accounted for in 30% of the Canadian university studies. So it was missed and not included by 70%. When we're looking at heart murmurs, in our data, in Aspetar, we have the wonderful privilege of having some amazing sports medicine physicians. Indeed, in the cardiac database that I have, over 19,000 screenings, we've had 44 sports medicine physicians perform the physical exams. There's an average prevalence of 3.4%. That was a median. But among some sports medicine physicians that performed over 100, the prevalence of a murmur or recording of a murmur was as little as 0.8%. So it varies differently. And again, it's about the continuity of care and understanding what we are looking for here. Is it simply a physiological murmur, or is it only a pathological murmur, or indeed including physiological ones as well? Now, a study from University of Washington again highlight that there is a poor correlation between the presence of a murmur in general and structural heart disease. And the rate of structural heart disease was not much lower in those with no murmur than with a murmur. And so again, it comes back to the aspect of what are we actually looking for in cardiac screening? Are we only looking for things that associate with sudden cardiac death, such as left ventricular outflow tract obstruction? Or are we looking for other things that may impact the athlete in the long term, such as a mitral valve prolapse? This study highlights, again, the inconsistency within reporting. 101 athletes, 3 physicians. 11 referred to echo. There were 10 disagreements between the 2 sports med fellows. And the cardiologist referred none of them on for echo. Now, I don't know who's right or wrong here, but again, it highlights the inconsistency. And so when we are looking for a murmur, we must ensure that you're doing it in a silent, quiet room, and you are assessing for physiological and pathological murmurs as well. With regards to blood pressure, the blood pressure and hypertension is one of the leading causes of cardiovascular disease around the world. An important aspect to look at. In our data, 2% of athletes, of male football players should I say, within Qatar have hypertension. Echoes similar findings to what has been seen in Italy, where 3% have been found. Differs hugely to the 11% found in the Italians among the general population, suggesting, as we all know, exercise is good for your health. Staggeringly, 27% of the athletes within this specific small study, this is not representative of our whole data, but 27% had a blood pressure that would now be in line with what the Americans suggest as hypertensive. And 42% had a family history. Now, family history and high BMI have been the strongest independent links of blood pressure. So again, if we are looking at the questionnaire, important to document this, important to ask the athlete about it, as we can, especially in Qatar, where we serially evaluate athletes, we can look at the progression of their blood pressure. How blood pressure is reported, however, from a methodological point of view, is highly variable. And you can see here, among 51 studies, only 40% gave any kind of methodology on their blood pressure taking. There are various different factors that the practitioner must be aware of when taking blood pressure. Position, seated, arm at heart level, back straight, make sure the correct cuff is used, things like that. Among this systematic review, 11 different definitions of what hypertension were there. So again, we need to ensure that this definition is consistent so we can interpret the findings around the world meaningfully. Altogether, this highlights that the sensitivity of pathology detection for sudden cardiac death conditions is actually quite low when using history and physical exam. Now we use, of course, ECG within the regular first-line investigations. And you can see here that the sensitivity of pathology detection improves significantly with ECG, and sensitivity and specificity are both improved massively. So there is, without doubt, benefit of including the ECG within the cardiac screening realm. We must, however, consider various factors with regards to the implementation of ECG within screening. First of all, with definitive outcome data, and there's only one study. And this one study comes from Italy, and they found an 89% reduction in sudden cardiac death in screened athletes compared to unscreened athletes. And this is great. This has supported the use of ECG screening around the world. It's 15 years since that last publication, so I'd love to see more data. We also have to acknowledge that this study is done just in Italy, and within Italy, the region of Veneto. And so we have to be mindful of when implementing ECG screening around the world. And we don't know whether these results can be replicated in other countries. There's no RCT on sudden cardiac death prevention and screening. Now, other studies from a longitudinal but retrospective design will be emerging. Indeed, our now 11-year data will hopefully go some way to showing the effectiveness or the data regarding ECG screening in athletes. Now, with regards to false positive rate, now this has been one of the main criticisms of ECG screening. And indeed, 11 years ago, in our study, 22% of athletes had an abnormal ECG, a false positive finding. Over the years, this has decreased to just between 3% and 5%, a fourfold decrease in false positive rate in our study. And this, we feel, falls within the realm of clinical acceptability. But we have to understand that this being done by qualified personnel is important. The ECG interpretation guidelines have gone a long way in aiding the physician to be able to interpret the ECG, distinguishing between physiology and pathology. But we must ensure that the people are experienced in sports cardiology and athlete heart. With regards to cost effectiveness, now you can see here there are various different costs for cardiac screening around the world. Indeed, in our study showed a history and physical exam cost of $144. I have to highlight that that is including a sports medicine consultation, so slightly different to the others as well. When we look at it though, it can be as low as $54 using a charity within the UK, but it's as high as $600 when the study from Wheeler et al. In 2010 averaged the charges of 20 random Californian hospitals. Now, I extrapolated this data for inflation, so that's not the data found in the studies, but I just wanted to put it at a level playing field. Now, all of this matters with regards to cost effectiveness for the detection of cardiac conditions, because that is what we are aiming to do. Now, the best practice is to use a quality adjusted life years. Now, we didn't do that because we had doubts about the methodology of incidence of sudden cardiac death within athletes at the time. Thanks to recent studies, that has improved. But NICE in the UK suggests that a strategy or screening thing is cost effective if it's below the cost of $42,000. The Americans suggest it's cost effective if it's below $50,000. And so you can see that 3 of those are around that level. Now, ours and the British study, and indeed the Spanish one, are dependent on us detecting a sudden cardiac death condition, and that ultimately protecting a life. Now, the World Health Organization again stressed that quality adjusted life years should be used, but based on a GDP of the country. And it's important to highlight that the GDP of the UK is $2.4 trillion. In Spain, it's just 1.4 trillion. And therefore, something that may be cost effective in the UK may not be cost effective in Spain. And when cardiac screening is a tool used around the world, it's important to highlight and understand that prior to implementing a cardiac screening program. Now, as I move on to echo. Now, echocardiogram at present is not recommended as first-line strategy during pre-participation screening among the major cardiology organizations. However, sporting organizations such as FIFA, UCI mandate its use within the first-line screening. And indeed, in a questionnaire targeted at healthcare providers who perform cardiac screening, among 603 of them, were just 6% adhered to those guidelines of not using echocardiography. 37% said that they always performed cardiac screening with echo in the asymptomatic first-line investigation. And so given that amount of people are performing echo, then why do the recommendations suggest against its use? Well, this is the study from our group, and we identified among the athletes that we screened, no athlete with significant pathology with a normal history, physical and ECG had an abnormal echo. And this was reiterated among several findings. Within our group, this would lead to a 47% reduction in the cost of the overall program. Now, the UK study looking at adolescent football players, out of 11,000 screened, identified 4 with a sudden cardiac death associated condition, with a normal history, physical exam and ECG, but an abnormal echo. And despite that rate being incredibly low of just 0.04%, it highlights that there may be conditions, as we already know, that are not able to be detected on ECG, but may be detected in other imaging modalities. Indeed, that's one of the arguments for using echo within screening. The detection of non-sudden cardiac death related conditions, such as bicuspid aortic valve or mitral valve prolapse, may enhance the sensitivity of the screening for such conditions. Others, such as coronary artery anomaly, are also better detected on echo, of course, than ECG certainly, although that has to be done by an experienced physician. On-site echo may reduce referral rates by 40 to 60% by doing it in the same day. And certainly from a personal perspective, by doing tests in the same day, it allows you to feel a bit more reassured. The psychological impact of having to wait several days or weeks is quite difficult. So being able to do a scan on the same day is useful, but it does require the funding and logistics to be able to do it. Indeed, the American Society of Echocardiography caution against its use outside of a carefully controlled setting. And that refers to the sports cardiology expertise and the comprehensive non-invasive imaging as a follow-up in case you find an abnormal finding. With regards to false negatives, they are also a concern within the use of echo. certain conditions may not be readily detectable by some forms of imaging, apical hypertrophic cardiomyopathy just being one. With regards to false positives, I mentioned anomalous coronary arteries above, but again, it takes a skilled practitioner to be able to identify their origin. And indeed, even among some experienced sonographers, they may have an inconclusive finding with that. And what that does is mean they would probably have to undergo a CT scan. And so false positive findings may occur there. Now, there's no consensus on what kind of echo scan to be included. We in Aspetar include a full evaluation of the echocardiogram, but some are suggesting the use of just a 5-minute protocol. And again, it all goes back to what are we trying to do? If we're just trying to identify certain conditions, then okay. But if we're trying to fully look at the health of the athlete from a cardiovascular point of view, maybe we do need to do a full-scale echocardiogram. And so the value of echo has been yet to be proven among longitudinal data. Now, again, thanks to all the stuff that we've been doing over the past few years, we will hopefully have some of this data available in the coming months, fingers crossed. There is also the additional cost. It costs to buy an echocardiogram. Sonographers also require a salary. But also, these sonographers and echocardiographers are skilled practitioners. In the UK, the British Society of Echocardiography require 250 scans to be performed, in addition to various other tests to be passed before they can be certified as performing an echocardiogram independently. And so these really are highly skilled practitioners. We must ensure if echo is done, we have available further testing in case an abnormal finding is found. And of course, time. It does take time to do an echocardiogram as well. So that has to be a consideration as well. So who should we be screening? Well, the definition of an athlete is from the Greek athlon, to compete for a prize. But determining who is an athlete is the tricky part. And therefore, if we are screening because athletes are at higher risk, who is screened? Well, the different organizations seem to have various different definitions on what they mean by an athlete. And this again complicates our understanding of not only comparing literature, but also for the organization as well. In these recommendations may say one thing, while another, for a different definition of an athlete, may say another. The international criteria for ECG interpretation suggests that an athlete is an individual who engages in regular exercise or training for sport or general fitness. Now, this is quite a vague, broad definition of an athlete, encompassing quite a lot of people. And similarly, this EACPR definition uses the term athletic participant. And so are these athletes? Should these be undergoing cardiac screening? Again, with broad definitions, it's open to various different levels of interpretation. And none of these guidelines, for example, also include the Paralympic athlete in their distinction. That's an important consideration to make as well. This other guideline suggests that training hours should be the measure of athletic status as well. But we have to understand that here they say a recreational athlete exercising over 4 hours a week. But even though they are classed as only recreational athletes, they may be pushing their bodies to the limit like the best athletes. And there's a large growing population of these individuals. Indeed, in the UK, there's over 200 marathons every year. And so the number of these people participating, or athletic participants or athletes or whatever you want to call them, is increasing. And should we be screening them? Similarly, with the young athlete, numerous cardiac screening recommendations recommend screening in childhood. But when we look at this Australian study, I know Australians are sport mad, but participation in competitive sport peaks at the age of 10 to 14 years old. 40% of these children are registered in a sports team. And so given the vast number of competitive athletes at this age, if that's what we are using as a definition, it makes the questions regarding costing, resources, and infrastructure all the more pertinent. Most children at this age are not affiliated with well-funded professional teams or governing bodies, but may be training up to 15 hours, maybe 20 hours a week for like a gymnast or a swimmer. And so these, while being amateur, are training incredibly hard. You can see the rate of participation in competitive sport decreases significantly to just 12% by the age of 20. And this, in perspective, makes us look at the group of athletes who are supposedly recommended to be undergoing cardiac screening. And when we consider that pediatric cardiologists in the UK are quite a rarity, there's only over 100 of them in the UK, only just over 1,000 in the USA. And so given these young people are quite a specialty, indeed pediatrics is of course its own specialty, we surely don't have the infrastructure and resources for pediatric cardiologists to be evaluating all these athletes. I want to stress again that these children are training a lot, indeed up to 7 times a week. So should we be targeting screening? Well, the notion, I have talked about this in one of the Aspetar journals with GDOPLs. If you want to take a look, it'll be on the Aspetar website. But targeted screening is based around the notion that there are some athletes who may be at higher risk than other athletes. But it comes down to the moral question of equality versus equity. Is it discriminatory to screen athletes but not some others? Because if you don't screen, you don't risk ultimate disqualification of from sport. And conversely, although some groups are at lower risk, they're not completely at no risk. And so these are important factors to consider. In addition to, once again, I want to bang home on this point, resources and infrastructure. We should be targeting screening only if there are the necessary resources in place. Now, I've took the concept of this slide from Kim Harmon, who did a wonderful lecture on the Institute of Sport and Exercise Health symposium, which is on YouTube if you want to look at that. So finally, when we look at when should we be screening? Well, the European Society of Cardiology and the European Paediatric Cardiology Association recommend screening should be performed when athletes are starting their competitive activity. With 65% of athletes' sudden cardiac deaths occurring before the age of 17, according to a Barry Marin paper from 2009. By screening at an early, it may seem apt, by screening at an early enough age, we could identify cases associated with sudden cardiac death at a time when they're not financially dependent on their sport. However, you see here, when we look back at this Australian study, 30% of the population between the age of 5 and 9 years old were engaged in competitive sport. And indeed, these studies are including athletes between the age of 5 and 8. And this is what the recommendations say, if they are going based on the fact that they are a competitive athlete. But we have to consider, what are we looking for by screening athletes at this age? Other organizations suggest screening should begin between the age of 12 and 14. This is likely owing to the onset of puberty. And if we look at the maturation and development of children, girls have their peak height velocity typically at the age of 12, and boys at the age of 14. However, the beginning of this adolescent growth spurt can range from 9.5 to 14.5 in girls, and 10.5 to 16 in boys. Skeletal maturation can vary significantly as well. 2 boys with a chronological age of 9 may have biological ages of between 6 and 12. Now, this is fundamental to the timing of cardiac screening. Adolescence is a time when genetic cardiac disease may present for the first time, and this is typically presents upon or after the point of puberty. So together with the unpredictability of disease penetrance and the etiology, it means that a single screening before this point of maturation, which may differ significantly in different children, may allow a cardiac disease to go undetected. And this has been seen within studies of Brugada syndrome and hypertrophic cardiomyopathy. Indeed, once again, referring to Barry Marin, he did a study where they highlighted that a single echo before the age of body growth or maturation does not exclude disease. And it leads quite nicely on to this study of adolescent football players. I mentioned it before, 11,000 athletes were screened with history, physical, ECG and echo. A monumental effort and an amazing study. 42 players were found to have cardiac disorders associated with sudden cardiac death. Now, if we think about why we are screening, this is a great example. They identified 42 athletes that may have gone on to have a sudden cardiac arrest that were perhaps prevented. We don't know that, but maybe they were. However, 8 deaths were attributed to a cardiac cause, and 6 of these had a normal screening. There's a 7-year period between screening and sudden cardiac death. And so it highlights that these athletes are adolescents. They were screened between the ages of 15 and 17. And it shows that perhaps if these athletes haven't reached maturation, a one-off screening prior to this age may not be optimal. And indeed, within this study, some of the athletes with sudden cardiac death had hypertrophic cardiomyopathy or arrhythmogenic cardiomyopathy, which are notable in their disease penetrance often occurring after the age of maturation. On the back of these results, the English FA changed their screening from 16 years old just to 18, 20 and 25. Now this relates to them recommending serial evaluation, and this study recently published a couple of weeks ago, the first of its kind, and it's a shame it was only a research letter, as I really wish there was a bit more detail to kind of get my teeth into. But anyway, the first evaluation showed this amount of abnormal screenings. Repeat evaluation accounted for 65% of diagnoses of cardiovascular disease related to sudden cardiac death. It shows that repeat screening is necessary in the evaluation of athletes, this within adolescent athletes. Now, I'm going to give you all a little bit of a treat. Now, while I need to update this data and indeed do a little bit of tinkering, this is a preliminary stuff from what we've found from, I've entered now 19,000 ECG screenings, and we've come into a point where we've got a bit of longitudinal data. And although our athletes were a bit older, certainly not just adolescents, this is a number we found on first screening. On second, third, fourth, 10th screening, we identified up to 27% more. So while less than the 65% in the other study, it represents an important point where serial evaluation does appear to be necessary. But again, it's highly dependent on infrastructure, resources, and sports cardiology expertise. We must ensure that this is available to the athlete. So what did the recommendation say? Well, not a recommendation, but we, in addition to the NCAA and probably quite a few others, recommend yearly or have yearly screening. The ESC, the Pediatric Association, and the FA recommend screening every other year. And the PPE in the USA recommends screening every 3 years. Now, the American Heart Association, IOC, and the EACPR don't have a recommendation on how to screen. And so we really must have more longitudinal data looking at this. Like I said, hopefully we are going to be publishing something soon on this, and hopefully adding to the sports cardiology literature. And hopefully we can get to a point where there is a more uniform approach, and for the doctor assessing how often they should be performing cardiac screening, there is a solid recommendation based on good levels of evidence. So to summarize, the W's. Why? Cardiac screening does aid in the detection of silent conditions which may predispose an athlete to sudden cardiac death. It has the opportunity to identify other non-cardiac death-related conditions. Also, other factors of evaluating other factors such as reviewing and education with the athlete, and offers a doctor the opportunity to build a relationship. History and physical is limited by low sensitivity and false positive rate. The ECG does seem to offer a better sensitivity and false positive rate, acknowledging though that no RCTs are available, and hopefully we get to a point where these studies are being done. All components require careful consideration, execution, and review by an expert, experienced physician. And the resource, financial, and logistical implications must be considered prior to any screening. And that is a key take-home from this presentation. A clear and consistent definition of what an athlete is must be sought. And in terms of when, more longitudinal data is needed on the time of initial cardiac screening and how often this is done, and particularly around the stage of adolescence, which is a crucial time for one's development and also the expression of serious cardiac disease. Now, I'd just like to thank the 44 sports medicine physicians that have helped us along the way. And without their input, without their assistance and help doing their daily job of performing these physical exams, we would not have any data to publish. And so it is with a huge heartfelt thank you. I appreciate everything they've done. And then finally, thank you to all the international experts we have had along the way, the cardiologists that have been there to evaluate and support each and every athlete in terms of their cardiovascular health, the echocardiographers, the pioneers, the people who set up the cardiovascular screening program in the first place, and importantly, the GSOs, the administrative staff, and the nurses, who every single day without fail were there with a smile on their face performing these evaluations. And without them, again, this simply could not be done. And so a huge, huge thank you to every single one that has aided us, not only in the athlete screening department, but in the research that we have done as well. So as my time in Aspetar and Qatar comes to a close, I thank you very much.